me thank the organizers for giving me an opportunity to have a few words with the cardiologists about the non-ST elevation myocardial infarction. We've been having so many webinars. It's actually quite difficult to select a topic nowadays because we've been talking so much about so many topics. I thought that we should have some kind of a discussion today, and I selected this because this is something new that's cropped up. And what I felt is we will go ahead and discuss something that is going to be a little different out of the box so that we'll have something to discuss at the end of it. So thanks, Dr. Vivek Rana, also for your kind introduction. And I shall be talking over the next 20 to 30 minutes on ACS, non-ST elevation myocardial infarction, top updates. I'm not going to cover you through the whole thing because all of us know about non-ST elevation myocardial infarction. So what I will do is take you through a few important points on that which I thought were quite relevant. So the first point I want to talk to you about is about what is unstable angina and non-ST elevation myocardial infarction. If you remember the old guidelines, we used to have it as ST elevation myocardial infarction and unstable angina bar non-ST elevation myocardial infarction. Now we have a clear understanding that unstable angina has a substantially lower risk of death. So what is the differentiation? The cardiomyocyte necrosis as measured by the troponin reliefs changes the whole scenario. And this correlate has been found to be quite significantly different from the unstable anginas. So now we don't talk about unstable angina, we talk about non-ST elevation myocardial infarction as a separate entity these days. The second point of interest is the high sensitive troponin. Now HS troponin has been given a lot of importance. We don't talk about troponins, we don't talk about other myocardial necrotic enzymes, we only talk about HS troponin because here we speak only this because it is recommended over the less sensitive ones, primarily because they provide higher diagnostic accuracy. Cost-wise, both seem to be pretty much the same. Now, we should also remember that there are several other factors which can increase the troponins. How, why, there are a whole list of things that I mentioned. I don't want to go through the list, but remember that there are several other differential diagnoses for increase in troponin. It's not restricted to cardiac alone. This is a lot more interesting today because when you look at troponin, we have been using the conventional troponin assay for quite some time. Now, what we are looking at is the highly sensitive troponin assay. Now, what is the difference between the two? The conventional assay used to measure it in micrograms, and only when it goes more than 0.040 or 0.030, we were thinking that it was pathological, considering that there is going to be myocardial necrosis. Now, what happens is highly sensitive troponin, if it is going to be measured, it is measured in nanogram per liter, which is 1,000 times more sensitive. And if you look at this, the limit of detection is going to be 1 to 5. There's no specific number. Mind you, it's not a specific number. The reason we'll see in the next slide. And there is a big range of normal. And if it is above the 99th percentile of the normal, then you call it myocardial injury. It is not going to be myocardial infarction. Increase in troponin is called myocardial injury. Now, another interesting point in this is, if the highly sensitive troponin goes more than 50, it is more or less similar to the conventional troponin. So this is going to be very useful in the early phase of myocardial infarction, wherein it is going to be at a much lower phase and much lower level of myocardial injury. Now, the next point is, whenever you start using highly sensitive troponin, you must always understand this. Each kit that you use is going to have different values. For instance, let's look at the first one by the Roche. The highly sensitive troponin, the very low levels of minus or less than 5, if you look at the trop I from Abbott, it's going to be less than 4 nanograms per liter. Now it's for low levels 12 and 5. So 1 hour change should be less than 3, less than 2. So what I'm trying to prove is that you must understand it is not going to be a standardized level above which or below which it is low or very low or normal or abnormal. You must understand, use the kit and use the references specific for that kit because it is very, very important to make a diagnosis. The example is this. So if you have somebody coming into the suspected non-ST elevation acute coronary syndrome, this is going to be very valid because this is what we're going to be doing in future. Now we have what is called as the 0-1 hour rule in, rule out algorithm. Now this is the simplest. Before we used to say, make a patient wait for 6 hours in the emergency, trop should be negative over 6 hours, and then only we say send the patient out. No, we don't have to do that. If your patient has got a very low level, now let's take the Roche kit and see what happens. The very low levels is going to be less than 5. If you have a very low level or a low level, repeat one after 1 hour. After 1 hour, what is going to be the value? If the value does not change by 3, less than 3 change, then you rule out myocardial infarction, you can probably discharge the patient. Now, if it is not the case, what do? If you have a value that goes more than 5, then it rules in. Or if your initial value is high, that is going to be more than 52 in this particular scenario, you rule in myocardial infarction and start treating the patient aggressively. Now, what is going to be the intermediate factor? Now, what is the intermediate factor? We say, let's say we have a value of minus, let's say about 5 or 8, and then the value goes by about 4, then you put them in the observation and repeat another trop after 3 hours. Now, you must also remember, if the trop is detected very early, you do a HS troponin, within 1 hour, the chance of picking up in 1 hour are low. So if the chest pain window is less than 1 hour, you have to mandatorily do a 3-hour troponin repeat again to rule out myocardial infarction. And the initial value, if it is high, it is very prognostic. And among the two, the prognostic accuracy of troponin T is better. Compared to though troponin I is very specific, prognostically, the troponin T seems to be much, much better. The negative predictive value of these troponins is 99%, saying it's fantastic because you're going to miss just 1% of these patients. Something like what we remember those days as the D-dimer test. So the negative predictive value of these highly sensitive troponin assays, the 0 to 1 hour algorithm is 99%. So what is the positive predictive value? 70%. So you're going to have 30% of the cases which are actually going to be not having myocardial infarction, but positive. But mind you, these 30% will have some important reason for you to have an invasive coronary angiogram. Like they may have a myocarditis or a Takotsubo cardiomyopathy, or there will be some other reason wherein they will benefit from an invasive study. So even if the positive predictive value is 70%, if it becomes positive, it still is clinically very, very relevant. Now, practically, while using the highly sensitive troponin, there is a lot of stress on this particular test. That's why I'm spending a little more time on this, because this is what we are going to be doing practically. Once you've drawn the 1 hour sample, the time taken to process it is about 1 hour. Now, the next sample has to be drawn in 1 hour. You draw the sample, because if you delay the sample by more than 10 minutes, you're not going to have accurate results because the test is validated over a 1 hour period. If you miss the 1 hour window, straight away go for the 3 hour window. So what you have to do, draw the sample 1 hour, draw a second sample after 0 and 1 hour. So after the 2 samples, if both are not suggestive, let's say it comes into the low risk category, the chance of having an MI at index visit is less than 0.3%. He said the negative predictive value is 99%. If not, you observe the patient for 3 hours, do an echocardiogram, repeat a 3 hour sample. Again, it goes into a category that is going to be not very significant. The intermediate risk has a 10% chance, so you observe for 3 hours. If at any point the values are high, the difference between the two values becomes significant according to the kit that you use, then you can go ahead and plan for an early coronary angiography. Now, I think you should all understand this concept of 0 hour, 1 hour, and if the time window is less than 1 hour, do a 3 hour sample. And by 3 hours, if you're negative, don't have to wait for too long. There is a very low chance of getting a myocardial infarction or an ST elevation or a non-ST elevation MI. So you can straight away discharge the patient, ruling in, ruling out. But what has become more problematic now are the confounders. What are the 4 major confounders? One is the age. As age goes up, the chance of having a false high are going to be very high. In fact, there's been a 300% difference between the healthy young and the healthy very old. So that has to be taken into account. In the elderly, you have to take it with caution. Again, when there is renal dysfunction, whenever the creatinine is elevated, again, there can be a 300% variation. Use that with caution. Another important factor we already discussed was the time window, the chest pain duration. Very early on, the values are going to be very normal. And as the time increases, the values are going to be more abnormal. So this is also important. There also the variations are going to be 300%. Women have a lower level of troponin. Remember that, because that variation is going to be about 40%. Now, if you're going to use HS troponin, remember these 4 variants or these 4 confounders, which you have to be taking into account in clinical practice. Now, the other biomarkers, what happened to the conventional troponin? Not spoken of, not discussed. But if you don't have a choice, you can still go for that. What about CKMB, which we have been using for ages? You routinely don't have to use it. The only usefulness of CKMB today is that it rises and falls quite rapidly, and this can be used to diagnose reinfarction. Apart from that, it is not classically useful, and it is not useful at all. The newer factor that has been discussed quite a lot is what is called as the Coprotein. We don't use it much here. Coprotein basically is the C-terminal part of the vasopressin hormone. It is not related to the heart. It is actually released as a quantification of the endogenous stress level. It does not have an additional value when a troponin is assayed. But in an unusual scenario where if you don't have a troponin, that is the only scenario it is useful, you can use a copeptide to rule in or rule out these patients with a problem. So this is going to be useful there. Now, what is going to be the next one? The natriuretic peptides. The natriuretic peptides in a non-ST elevation MI without the heart failure. What is the usefulness of this? Now you will understand that this has an additional prognostic information. So if you do one early, you will notice that there is an increased quantification of prognosis by either talking about the risk of death, risk of acute heart failure, or whether they're going to develop atrial fibrillation also subsequently. A lot of people are raising their hands. I will just stop share for a moment and see if there's going to be something. And if anybody wants to say something, Vishal, you've raised your hand. Anything specific? Is there specific something? Everybody is raising their hands. Is there a problem? You please put it in the chat box or in the question answer. I don't find anything there. So I'll just proceed with my talk at this point of time. So what is going to be the next issue? The next point that we're going to be talking about is going to be the CT coronary angiogram. Now, CT coronary angiogram has had a lot of importance. Now, how many of you use CT coronary angiogram? Now, in India, we don't use CT coronary angiogram that often in a setting with unstable angina or non-ST elevation myocardial infarction. Now, what about the negative predictive value and the positive predictive value? The negative predictive value of this is going to be 90%. Now, this we are talking about the verdict trial, and the positive predictive value is about 87%, quite good. But practically, there is something you must understand about when to use the CT coronary angiogram. Two important points. The CT coronary angiogram is very, very useful when you want to exclude coronary artery disease, not to include. And it is also less useful in a patient with a known coronary artery disease. Somebody de novo comes with chest pain. If you want to exclude coronary artery disease, then you do a CT coronary angiogram and rule out coronary artery disease. Here, it is quite useful. Otherwise, it is not going to be really very, very useful in these group of patients. So that is the other point. Now, the first thing that when a patient comes to you with chest pain and suspected non-ST elevation myocardial infarction, when they come to the emergency, your emergency registrar calls you, and what do you tell him? Load him with the aspirin, load him with the, the P2Y2 like clopidogrel, and then you give him a statin, give him a sorbitrate, and do all this blah blah. Now, what about the role of routine pre-treatment of the P2Y2 inhibitors? This is what we say normally. This is what we keep saying. Now, the 2020 guideline has come up with some interesting facts. It looked at the trial called the ACOS trial, wherein prasugrel pre-treatment with and without was compared. The final results in terms of primary efficacy were pretty much the same, but the difference came in terms of bleed. There was a significant amount of increased bleeds when you pre-treat with prasugrel. Now, does it apply to prasugrel alone? It was statistically significant. Look at the p-value here, 0.01. Now, this was studied again by the Swedish SCAAR registry, the SCAR registry, and they compounded the results and found that for infarct-related artery occlusion, stent thrombosis, cardiogenic shock, comparison between the pre-treatment and the post-treatment with either it could be ticagrelor, prasugrel, or the clopidogrel, they found there was no significant difference, and they also found that there was an increase in incidence of bleed. So today, the recommendation is, in those who are going to be pre-treated, where the coronary anatomy is not known, and you're planning an invasive management, there is no routine recommendation for pre-treatment for P2Y12 inhibitors. Now, this is something new, because our conventional concept has been to load the patients with P2Y12 inhibitors, so you don't have to load these patients with P2Y12 inhibitors in the emergency. So when do you do it? Now, if you look at the comparison between clopidogrel, prasugrel, ticagrelor, and the cangrelor, we don't use much of cangrelor, so I leave it. You look at the onset of effect. It is going to take 2 hours for clopidogrel to start acting. But what about prasugrel and ticagrelor? They start acting between half an hour to 4 hours between both the drugs. So if you can have a drug that's going to happen within half an hour to 1 hour, by the time you finish the procedure, that is going to be fair enough. And you always load these patients within the cath lab. Once you decide to do a PCI, you go ahead and load these patients. This is going to be significantly useful. Well, that makes sense. So you don't have an increased incidence of bleed. You have a perfectly acceptable scenario where you're going to load these patients on the table and then proceed with an angioplasty. The drug starts acting quite fast. Now, the next question that crops up is, what is going to be the first among the equals? The equals we have thought are prasugrel and ticagrelor. Now, what does the European Society of Cardiology say about it? Now, it took into consideration this beautiful study which came up last year, which is the ISAR React 5 trial. Last year ESC, this was presented. Now, interestingly, the aim of this trial was to prove superiority of ticagrelor over prasugrel in a real-world scenario of acute coronary syndromes. This is an open-label trial where the operator was able to decide which drug he wanted to give. And when the two drugs were compared, the results showed quite the contrary. You look at the cumulative incidence of events, look at the red line, ticagrelor had more events compared to prasugrel. There was a statistically significant, nearly 3% absolute risk reduction. Not only that, generally we say prasugrel bleeds more. Now, if you start looking at the bleeding results, you found out that the bleeds are actually less with prasugrel. Now, this was very, very surprising. Now, is this the only trial based on which the European Society of Cardiology came up with its conclusion? No. Interestingly, there was another study which studied the flow-mediated dilatation following an angioplasty in patients between ticagrelor, prasugrel, and clopidogrel. They found that the best results with the flow-mediated dilatation post-PCI, which is supposed to be a good factor, was with prasugrel. Compared to both ticagrelor and the clopidogrel, the prasugrel was superior. Also, if you look at the interleukin-6 levels, which are the inflammatory markers in acute coronary syndromes, prasugrel had the lowest levels of the interleukin-6. So net result is that today, interestingly, the European Society of Cardiology has come up and said, prasugrel should be considered in preference to ticagrelor for non-EST elevation acute coronary syndrome patients who proceed to PCI. This is a very interesting statement. It should be preferred. It is not number one, but it should be preferred. So when you're going to go for a PCI, it has clearly come up with a statement stating that it is a preferred drug when you proceed for PCI. This is something that's new, interesting. I didn't expect the guidelines to change so fast, but it gave enough justification and changed it. Regarding the antithrombotic drugs, the enoxaparin, fondaparinux, unfractionated heparin, bivalirudin, there is not much of difference. Generally, it says you can use this, but the major change from the previous guideline is that previously, class 1 indication was given to bivalirudin in place of 2B3A and unfractionated heparin, but now this has come down to 2B, indicating this is not recommended. Bivalirudin may be considered as an alternative, comes down to 2B recommendation stating that you generally don't prefer bivalirudin. This is another important, interesting change. Next question is, once you've treated the patient acutely, you give the antiplatelet drugs, the conventional accepted level of treatment is 12 months of DAPT. Now, there are several studies that are coming up which have said shorter the duration of DAPT, you de-escalate to shorter duration, 3 months, 1 month. All the trials have come up, but it's not come up in the recommendations. But the recommendation today is definitely 12 months of DAPT seems to be the order following a PCI or for an acute coronary event or any kind of non-ST elevation myocardial infarction, whether it's going to be stented or non-stented patients, it is going to be there. Whatever be the kind of stent also, it is pretty much the same. Now, what about the guidance generally? Generally, whenever there is a very high risk or a high risk patient, the best drug seems to be clopidogrel because one thing is accepted. Clearly, one thing we accept is clopidogrel has the lowest incidence of bleed. So that seems to be the order. So what about the low risk patients or the conventional patients? What you do is you can go for aspirin, ticagrelor and continue with ticagrelor, or you can start with aspirin, prasugrel, ticagrelor or clopidogrel. And then at the end of 12 months, depending on the ischemic risk, you look at the bleeding risk. If you have a low bleeding risk patient, depending on the ischemic risk, either you can go for a continuation of dual antiplatelet therapy, which could be an aspirin ticagrelor or an aspirin clopidogrel or an aspirin prasugrel, or the newer therapy that is recommended is the aspirin with Rivaroxaban, which is called the dual pathway inhibition or a dual antithrombotic therapy, or the DAT as it is called nowadays. Now you can use one of these therapies. Now, when do you use what? Now, so far we have been speaking about this only in the chronic coronary syndromes. Now, 1 year afterwards, it is clearly discussed now, you can start using these drugs too. Now, how do you classify these patients? The clear understanding is that those patients with high thrombotic risk, the risk enhancers are going to be diabetics, recurrent myocardial infarction, multivessel CAD, polyvascular disease, meaning that the coronary and peripheral vascular disease, early premature coronary artery disease, concomitant inflammatory disorders, SLE, CKD, these are all technical issues. Or if you have a non-complex, basically meaning diabetes, recurrent myocardial infarction, polyvascular disease, and a renal failure or a heart failure, these patients are more prone for subsequent events. Those patients are going to recommend, are they going to be benefiting from a long-term dual antiplatelet or an antithrombotic therapy. Now, clearly adding a second antithrombotic agent, which is class 2B beyond 12 months, has now come in to a second drug from a 2B to 2A, stating that you may use these drugs based on your clinical discretion. So you should have a low bleeding risk, and a high thrombotic or an ischemic risk. Now we have 4 combinations we have discussed. Now let's look at what are the 4 combinations. The first is the dual antithrombotic therapy, Rivaroxaban 2.5 milligram twice a day, in addition to an antiplatelet drug. And then second one is going to be clopidogrel 75 milligram in addition to aspirin. Prasugrel 10 milligram or a 5 milligram if the weight is going to be less than 60 or an age more than 75. Ticagrelor 60 or 90 milligram bleeding. Now, what is going to be the difference? How do you choose? Now, I will come to the right extreme. Look at the number needed to treat and the number needed to harm. We'll go from below. Look at the Pegasus trial. The number needed to treat is 84 and the number needed to harm is 81. What does this mean? So if you treat 84 patients, you're going to prevent 1 event. While if you treat just 81 patients, you're going to have a bleed. This is significant. The number needed to harm is more. Would you choose ticagrelor? I wouldn't choose ticagrelor, though it says so. This is the Pegasus trial data. Now, what about prasugrel and clopidogrel? Similar data based on the DAP trial. They said the number needed to treat is 63 in specific accepted patients, and the number needed to harm is 105, quite acceptable. What about Rivaroxaban? Rivaroxaban has had a lot of say following the COMPASS trial. Now here it has clear indications stating that there is a specific group of patients who are going to be having diabetic patients, polyvascular disease, chronic kidney disease, heart failure patients. But what about the number needed to treat? 77. Number needed to harm 84. So be careful. So these drugs also have the significant bleeding effects. So start looking at patients, look at the bleeding risk, look at the benefit. And if you're going to have a clear patient who's going to benefit, therein probably prolonged dual antiplatelet or an antithrombotic therapy is going to be beneficial. It is not meant for all the patients. So select your patients and don't bleed the patient, because it is going to be very difficult to explain a bleed to a patient who's going to be stable. So in clinical scenario, there are 3 patient characteristics. That is going to be the age, sex, race, whichever is going to be more prone. The clinical presentation, acute coronary syndromes, you have more chance of giving a long-term antiplatelet therapy. Clinical comorbidities, we already discussed. Chronic kidney disease, diabetes, PID, or heart failure are more prone, probably candidates for long-term dual antiplatelet therapy. Comorbidities, co-conditions, procedural aspects. If you have a more complex PCI, multiple stents, bifurcation lesions, they are going to benefit. But always weigh the ischemic risk, bleeding risk, find out which is going to be the soft spot where you're going to be comfortable and start treating a patient accordingly. There is absolutely no general rule. It's horses for courses. Select for your patient and start treating these patients. There is always a 6 to 8% chance of your patient having an atrial fibrillation already he's already on a novel anticoagulation or a vitamin K antagonist. A lot of things said, but one interesting point about this is this particular slide. Now, the default strategy, that was interesting. We said high bleeding risk, high ischemic, but the default strategy in a patient who's on DOAC seems to be 1 week of triple therapy, which is going to be dual antiplatelet therapy for 1 week alone, followed by double therapy with a NOAC and a single antiplatelet therapy for 12 months, followed by NOAC alone. You don't need antiplatelet therapy beyond 1 year for a patient who's undergoing a PCI. This is interesting because it's going to be standard recommended therapy is going to be for a patient who's going to be on a standard stenting, not bifurcation, not complex angioplasty. This is for stable patients. But if you have a high bleeding risk, possibly the same 1 week, and you can continue the dual therapy for probably 6 months, use with caution, and then go ahead with a NOAC alone after 6 months. Now, if you have a high ischemic risk, the triple therapy can be continued for a period of 1 month, not beyond 1 month, and beyond that, the double therapy for 1 year, and then you can change over to a NOAC alone. In all scenarios, beyond 1 year, remember, even in an atrial fibrillation post-PCI, you are not going to need a patient requiring antiplatelet therapy. All you're going to need is only that simple novel anticoagulation drug. So you just have to give one of those drugs. Which drug to choose? I leave it to you. There are a lot of guidelines on that. The 10th point I wanted to say is, when do you plan an invasive approach for these patients? Now, we have always seen these 3 scenarios, the very high risk, the high risk, and the low risk patients. Now, the very high risk patients, there is no data. What are these high risk scenarios? Cardiogenic shock, hemodynamic instability, recurrent ongoing severe chest pain, life-threatening arrhythmias like ventricular tachycardia, mechanical complications, patients with an acute heart failure, ST, depression in more than 6 leads, probably meaning that there's going to be left main disease. These very high risk patients are never subjected to randomized trials. So those patients, clearly, you do an immediate PCI. What is going to be an immediate angiogram? Less than 2 hours. Something like an ST elevation myocardial infarction. I'm sure all of you agree on that. But what about those patients who are going to be otherwise? Now, those are the patients who are called the high risk patients, wherein you recommend a standardized less than 24 hours following an ST elevation myocardial and non-ST elevation myocardial infarction, go for an invasive strategy. Clearly do it. Establish non-ST elevation, meaning that the troponins are elevated. Take them for an angiogram within 24 hours. No point in sitting on it. Now, if your patient is not in a center who can do a PCI, shift the patient within 24 hours and do a PCI. That is the recommended treatment. And when you do a PCI, you look at the gray score also. If it is going to be more than 140, the gray score is available all over the place. It takes into consideration the clip class, the blood pressure, heart rate, age, creatinine level, whether the patient had a cardiac arrest, ST deviation, and the cardiac enzyme levels, and comes into a scoring of 140, it means that the patient is high risk. Now, the 12th point is a little more interesting. How many times have you seen a patient whose ECG was sent to you from a hospital, which showed chest pain and ST elevation? So you've shifted the patient to your center to do a PCI. By the time the patient came here, they gave aspirin, clopidogrel, a little bit of sorbitol, and gave one shot of heparin there. The patient comes to your hospital, patient is absolutely chest pain free, and the patient's ST elevation is settled down. How many times have you seen this scenario? Now, this is the transient ST elevation segment. Now, what do you do for these patients? Do you do an immediate PCI? Or do you treat him like a non-ST elevation myocardial infarction? Because the trop is slightly elevated. Do you need to do? Now, this is a very elegant study that was done, published very recently in 2019. It shows that between an immediate invasive and a delayed invasive strategy, there is no difference. So in these patients, you can admit them, give them the heparin, and within 24 hours, you can do a PCI. You don't have to feel guilty. If you're feeling sleepy and you're sleeping at night, don't bother about this. Take your time, go the next day morning and do the PCI within 24 hours. So you can take your time and start treating these patients. Don't worry about these patients. You are going to be doing the perfect justice for these patients, right? Once you do an angiogram, what are going to be the findings? Don't be surprised, because 5 to 10% are going to have left main disease. You'll have to take the call at that point. 20% have no obstructive lesions, and 40% of the patients have some kind of a LAD disease. Now, this is a standard scenario. But many times, 40 to 80%, you have multivessel disease. Now, what is going to be the treatment in multivessel disease? You identify the vessel with the culprit. You open it up. Do you do a complete revascularization? The complete trial came in a ST elevation myocardial infarction. But summarizing all the data, today it is accepted. Even in non-ST elevation myocardial infarction, complete revascularization must be considered in all these patients without cardiogenic shock. Because if you have a cardiogenic shock, you probably have to go by the case and start treating them, probably the culprit vessel, and then look at the vessels and then start treating them. So complete revasc is also recommended in these group of patients. The last 2 points I want to talk about are the SCAD and the MINOCA. A few words about the SCAD, which is basically spontaneous coronary artery dissection. Now, what is SCAD? Basically, it's a non-atherosclerotic, non-traumatic, or iatrogenic separation of the coronary arterial tunics. And it is seen in about 4% of acute coronary syndromes. In women and who are less than 60 years, it is pretty high. It's about 22 to 30% of these patients have a SCAD or a spontaneous coronary artery dissection. Intracoronary imaging is a very useful tool. There are 3 types of SCAD. I'm sure all of us know about this. One is the multiple radiolucent variety, which is the type 1. The type 2 is a long diffuse intramural hematoma. Third is a focal stenosis. Now, how do you differentiate these group of patients? This is going to be the multiple lesions here. This is the long lesion, and this is the focal lesion seen, the type 3 lesion in these group of patients. Basically, when you have a high index of suspicion for the type 1 SCAD, it is going to be very easy. It maintains the staining, and you see those multiple lines that are there of dissection. It's going to be SCAD easy diagnosis. Now, if you have a smooth stenosis and you still suspect a SCAD, you can give a nitroglycerin and very carefully perform an IVAS or an OCT. OCT is more useful. Now, this is going to be very, very useful. But remember, if you're going to do this, give nitroglycerin, use it with caution, because if you are careless, you can propagate the dissection and create more problems. So use it very, very carefully. OCT is going to be a very useful tool. Finally, how do you diagnose and treat these patients? For patients who have obstruction and symptoms of obstruction, go for a PCI or a CABG. For those who are not, you can manage them conservatively and treat them. Now, how is this? The guidance actually did not come from here. It came in a beautiful paper in the JACC last year, which said, look at those patients who are having clinical high-risk features. Now, what are the clinical high-risk features? Those with ongoing severe chest pain, cardiogenic shock, sustained ventricular tachycardia, or a left main dissection. Now, these are patients who are going to having SCAD. Now, these patients consider PCI or a CABG. Now, when you have a left main disease, it is recommended to go for a CABG. Otherwise, you could go for an elective PCI if there is going to be an ostial left main SCAD or a spontaneous coronary artery dissection. Otherwise, you can go for a PCI also. If you don't have a high risk anatomy, like if you're not very sure about this, you can still go for a conservative management, because nearly 75% of these patients, close to even 90% of these patients, spontaneously resolve. So these patients, what you could do is wait, go ahead and start treating these patients again 4 to 6 weeks later, do a repeat angiogram, and they resolve most of the time. Otherwise, the treatment conservatively is going to be with an aspirin beta blocker and probably a statin, aspirin beta blocker, and probably a little bit of plus minus of nitroglycerin calcium channel blockers. When you have decided to do a PCI, go for probably a single long stent to cover the entire area, go to a clear edge to edge, or what you do a sequential interesting stenting. First, stent the edges, then you fix the center. Because if you start stenting from above or below one area alone, what you're going to do is you're going to propagate the stenting, propagate the dissection, and you once dissection begets dissection. So you have to be very, very careful starting to treat these patients. The high risk anatomy patients, you have to be very, very careful. The left main or a proximal lesions of multiple vessels, you have to be careful. The second point for completion, I wanted to say, because the European Society of Cardiologists discussed a lot about MINOCA. MINOCA is nothing but myocardial infarction with non-obstructive coronary artery disease. Now, the diagnosis is made based on a 99 percentile increase in the troponin, and you have to show a typical symptoms of ischemia, new ECG changes, development of pathological Q waves, and an imaging modality or like a wall motion abnormality or a CMR showing some kind of a change. It can be angiographic proof also. Now, how do you classify and treat these patients? Now, one thing is, two important modalities are very, very important in diagnosing and treating MINOCA. One is the OCT, and two is a patient who's going in for a cardiac MR. Now, if you have a patient with a myocardial infarction, do an angiogram and don't find much, the OCT and the CMR are very useful. How useful? Because you find plaque rupture, plaque erosion, angiogram looks normal. You could also have a single small lone thrombus like this. Coronary artery dissections can be there. You can have a small eruptive nodule, and the AMI can be detected by the CMR. Now, the largest study has been the Jedward et al. Study. This actually was published in August 2020 by the Interventional JAC, and it showed myocarditis in 29% and Takotsubo in 15% of these patients. Coronary artery spasm was found in 13%. Interestingly, 33% of plaque erosion actually did not have a late gadolinium enhancement on CMR. They did both together. And 20% of MI on CMR did not have an OCT abnormality. So you have both kinds of combinations, and how to treat these patients, we're not very sure, because the treatment so far is not very clear. In fact, the ongoing trial called the MINOCA BAT study, which is a study testing the aspirin and the beta blocker and also the statins in this particular trial. We are awaiting the results. It's going to take 2 to 3 years to come. If that comes in, we'll probably have a better answer. So finally, to summarize whatever I have been yakking along so long, first point is we have to differentiate between highly sensitive troponin elevation. If it is elevated, you make a diagnosis of non-ST elevation ACS. Otherwise, go for the 0 to 1 hour rule in, rule out protocol. If the chest pain is less than 1 hour, probably you have to do a 0-3 hour protocol. If you have a troponin elevation, you can still do a NT-pro or a BNP, which has additional prognostic information. Look at the antiplatelet drugs. No pre-treatment, but if you're going to use probably prasugrel if you're going for a PCI. Look at bivalirudin. It is not there in the picture anymore. And when you start treating these patients, early invasive therapy for those who are not at very high risk, meaning that not having hemodynamic instability or severe ongoing chest pain. GAPT for 12 months is recommended. Beyond that is not recommended. And this is the entire management strategy that is being discussed. It is there in the European Society of Cardiology 2020 guideline. I think you can go through it and come out. So the top points that I wanted to tell you was, first point, differentiate that there is myocardial injury or not. It is important because if you have troponin elevation, the prognosis is bad. Within 24 hours, do an angiogram and fix the lesion. 0 to 1 hour protocol is good enough. If the pain is less than 1 hour, or if you are in doubt, wait for 3 hours. By 3 hours, you will make a rule in or rule out the 99% negative predictive value, which is pretty good. Natriuretic peptides, do it because it has additional prognostic information. CT coronary angiogram is more useful when you don't have a known coronary artery disease. In a known coronary artery disease, it may not be useful. No routine pre-treatment of P2Y12 inhibitors in the emergency. It is not recommended. Prasugrel is probably the preferred drug when you do a PCI and on-table loading is required. Bivalirudin, not preferred. Extend DAPT beyond 12 months in high ischemic risk and low bleeding risk patients, not for all patients. Atrial fibrillation, shorter the duration, lesser the bleed. And early invasive approach, less than 24 hours for all patients with elevation of troponins. Transient ST elevation, you don't have to rush in and do an angiogram. Early invasive is the preferred, not the immediate invasive therapy. Complete revascularization, not the culprit vessel. You can go ahead and revascularize all the vessels. SCAD is a different entity. Try to manage conservatively. It spontaneously resolves most of the time. And remember, the dissection can beget dissection. Use it with caution. Minoca is treated a little differently, but you have to make a diagnosis. And probably at this point, we'll have to treat it like atherosclerotic coronary artery disease. With this, I will let you think over the questions. It's been a pleasure talking to you. I enjoyed preparing for this talk. Thank you very, very much to all of you for listening to me. And now I think I will go ahead and take questions if they're there. Thank you very much.
Excellent presentation, sir. You have covered almost all the topics, right from the diagnosis and management, then the associated conditions like spontaneous dissections, mimickers like Manuka. High sensitivity troponins are very important. Sometimes we see patients who have non-diagnostic ECGs, and we are in a dilemma whether to proceed with treatment of MI or not. The time frame you have told about 1 hour, 2 hour, 3 hour, it is very informative for centers who are not equipped enough to handle these patients. It was all in all a very good presentation. We would like to have any questions if there are any, please. There is one question, sir, from Dr. Parmasivan. How long we can continue DAPT after PCI? Though it has been answered by you in the presentation, but if you want to answer it again.
The current concept that happens is we are going towards lesser and lesser duration of DAPT. In fact, you will be surprised. There was one trial which was published 1 week ago with prasugrel, wherein they did a PCI without aspirin. Only prasugrel was given, and it was given at a dose of 10 milligrams, and it was continuing for over a period of 1 year. And this study in the initial 3-month trial that was published, there was no increased incidence of event. In fact, the entire trial, there was just 1 event. They compared it with aspirin and without aspirin, and it is being studied. The dual antiplatelet therapy, the aspirin has been there for ages. So we've never had the guts to stop the aspirin. But now we are talking about stopping the aspirin and continuing the P2Y12 inhibitor, probably because we feel that there is going to be less and less benefit of aspirin, and probably the GI bleeds are more. But one thing, standardized therapy is going to be for 12 months. But if it is not for 12 months, even 6 months of DAPT following a drug-eluting stent is acceptable. It goes up to 9 months. But the important thing is you must remember the complexity of the PCI that you're doing. If it's going to be a single stent, straightforward stenting, no complications, even 6 months is going to be good enough. 9 months is fair. But beyond 1 year, if you're going to continue it, you're only going to increase the risk of bleed. So you have to realize what patient you're treating, how you're treating, look at the ischemic risk like what I said. And based on that, I think you should probably start treating these patients. That's how you should be looking at it. Dr. Rana is not there, so I look at the next question myself. The timeline for HS drop is from time of onset or from the time of presentation to the hospital. Now, 2 things in this. 2 points are interesting in this. One is that the timeline is on 2 points. The time window. The window is the time window, the duration of chest pain of 0 to 1 hour. Within 1 hour of the onset of chest pain, you probably have to go in for a 0-3 hour protocol. But once the timeline for 0 hour and 1 hour of testing, that is what I mentioned in the separate slide, stating 0 is the point of contact and the time you draw the blood for the first sample. And the 0-1 hour protocol is the next sample is drawn at 1 hour plus minus 10 minutes. Beyond that, the 0-1 hour protocol does not work. If you have missed the 10-minute window within the 1 hour 10 minutes, meaning 70 minutes from the first sample, you probably have, there is a protocol for 0 to 2 hour also that is accepted. And if you miss that, probably go for the 0-3 hour protocol. The reason why we talk about this is, by the time you get the result of the 0 hour sample, it is about 1 hour, because the lab takes 1 hour to process the HS troponin. So that is the reason we talk about 0 and 1 hour, and the lab turnover time also has to be taken into account. The values are for 0 hour from the time of drawing the sample, 1 hour from the time of drawing sample, and 3 hours from the time of drawing the first sample. So that's how it goes. So the time window is different from the time 0-1 hour and 0-3 hour protocols. Role of GP2B in NSTEMI MI clear indications. Now, of late, we are generally not talking much about the glycoprotein 2B3A antagonist at all, basically because we have found out that the antiplatelet drugs are quite good. The prasugrel and the ticagrelor seem to be pretty good. And nowadays, there are more and more data on cangrelor. In fact, people who have been using cangrelor in the international studies and the forums for the Sky and other things. We keep talking more about cangrelor if you want more antiplatelet drugs, and if you want more powerful antiplatelet drugs. 2B3A probably for as a bailout strategy. In fact, I've seen a lot of people use it in an acute setting when the thrombotic burden is more, in a complex PCA wherein you expect more and more thrombus coming in when you think that the platelets are not going to be working. But if you use a proper ACT and use a good heparin during your procedure, and if you preload the patient adequately with either the shorter acting drugs like the prasugrel or the ticagrelor, I don't find much of a usage for the 2B3 antagonist. In fact, the usage of 2B3 antagonist has generally come down considerably. It is hardly being used, done already done so far. There's one more question in the chat just come. What's the approach to marginally elevated HS troponin in non-ST elevation? Once your troponin is elevated, it comes into two categories: the low risk and the very low risk, which is the green category I said. If that is going to be there, the patient probably qualifies for an unstable angina. If there's no emergency, you can take your own time depending on your clinical risk factor scenario and the kind of pain. You can either do an invasive management or a conservative management. One, if your HS troponin goes up, once it comes into the diagnosis of HS troponin elevation, there the chance of an MI is nearly 70%. That is the high risk category. In those patients, you must probably go in for an invasive coronary angiogram within 24 hours. You define the anatomy and start fixing the lesion. Basically, what happens is the plaque is unstable. So when the plaque is unstable, it begets more and more thrombus. So you have to fix the plaque. That is important. So you have to be looking at it. So if the marginally elevation is a gray area, in that area, you observe the patient, and therein the 0 to 3 hour protocol is going to be useful. If it is not going to be useful, then probably in a patient who's known coronary artery disease, you can still go for an invasive angiogram. Not a known coronary artery disease. Let's say it's a naive patient, not patient who you don't know, doesn't have it. Let's say he's a 40-year-old gentleman, some kind of vague chest pain, troponin is somewhere in the middle area, not neither going up nor coming down. The 0 3 hour sample is also not going. Echo is not very contributory. Those patients, what you could do is you could go ahead and try to do a CT coronary angiogram. That's what I said, the usefulness of CT coronary angiogram. If you do not know the anatomy, CT is useful. But if you have somebody who's a known coronary artery disease, let's say he's already got a 70% lesion working, what's the point of doing a CT coronary angiogram? It's not going to be very useful. In that case, probably going in for an angiogram might be conventional, or a regular angiogram is going to be more useful in these group of patients. Some more questions in the chat box. 2B3A. Indication of using NOACs, probably Rivaroxaban. Dr. Rahman has asked about Rivaroxaban. Now, Rivaroxaban, I told you, the indication is beyond 12 months. The standard dual antiplatelet therapy, if you're talking about Rivaroxaban of 2.5 milligram twice a day, based on the COMPASS trial, the indication in COMPASS trial were very, very clear. Now, the European Society of Cardiology clearly differentiated and said you must have patients with high ischemic risk and a low bleeding risk. Don't try to give it in all these patients with low bleeding risk. So you have to be careful. Those patients with high ischemic risk are going to be the diabetics, polyvascular disease, patients with a complex PCI and an acute coronary syndrome, and those patients who have had heart failure and a renal failure. Now, those patients are going to benefit from a NOAC like Rivaroxaban. Now, wait, periodically reassess your patient for the bleeding risk and start treating these patients. Now, how long to treat? How long do you continue? That's a little bit of a question mark at this point of time. But at least there is data to say that it can be useful, and specifically Rivaroxaban can be used in these group of patients. That's a dual pathway inhibition that is going to block both the antiplatelet and the antithrombotic regimen. And like I said, be careful about the risk of bleeds. Now, even in the COMPASS trial, there was an increased risk of major bleeding, but not life-threatening bleeding. So you have to be careful risking these patients. How much of the ischemic risk and bleeding risk is going to be there?
Sorry, I had a network issue. There is another question. Which agent should be used for thrombolysis in STEMI apart from streptokinase? You may answer it, sir.
Rana, you can also answer. I think. Yeah, go ahead. I think some network issue with Dr. Rana. I think he's coming in way. I think what happens is in a STEMI, it doesn't come into our network issues. Yeah, but I think nowadays what they're using is they're using more and more of tenecteplase. But I still think that if you can send a patient to a cath lab to get a PCI, primary PCI done within 2 hours, which is quite possible in any of the metropolitan cities, you can still ship the patient for a PCI because in front of your eyes you open the vessel. The efficacy of streptokin is about 60-65%. The efficacy of tenecteplase or the retiplase is going to be about 85%. You still miss it out in about 15% of patients. So I think the primary PCI is the goal. Don't talk about thrombolytic, but in COVID era, it's acceptable. I still agree that a lot of people are going to be scared and not worried. But I think the guidance has come clearly. If you still don't have a COVID, you wear a full PPE and go ahead and do a primary PCI. The recommendation is clearly come towards going in for a primary PCI today.
Yes.
I missed Dr. Rana, I missed the question on atorvastatin loading or not. I think you should go ahead and load all the patients with either atorvastatin or a high intensity statin with either rosuvastatin or atorvastatin. Both are beneficial. So I think you should be loading these patients definitely. It is only the pre-treatment with the P2Y12 inhibitors without knowing the anatomy that was in question. But otherwise, I don't think there should be a problem with these group of patients.
I think, sir, we need to, you address very rightly the role of CT angio. It is rather in exclusion of CAD rather than trying to diagnose CAD, which is being done in most part of our country. And you have addressed it correctly. I think if any more questions are there, there are no more questions, sir. There is one more question.
No, all these are answered.
How long? You have answered it.
We finished this question. I'm just removing the questions that are done. So I think we kind of answered these questions. Something in the chat box was there. Is there anything in the chat box also? Timeline was there. Role of low molecular heparin post PCI. Now, actually, the European Society of Cardiology recommendations, I actually was interested in the same question. I was looking at, there was no specific guidance on this, but he says post good stenting, he says you really don't need these low molecular heparins. You don't have to continue with low molecular heparins. If you have got a good antiplatelet in place, you really don't need to continue these low molecular heparins and heparins. And in fact, not in an ACS scenario, but within same day discharge following a PCI, for an elective PCI, is the vogue. So in an non-ST elevation myocardial infarction, probably I don't think you need to do it. It says you don't have to. After you get the patient out of the cath lab, you really don't have to give it. It's mentioned in the statement, but it's not come up in a big way. Probably we usually do this continue for about 24 hours if required, providing there's not much of a bleeding risk.
That too only in a complex PCI with a lot of thrombus burden and bifurcation or complex PCI.
Or when the flow is slow, or you don't have a TIMI3 flow or something, probably need to continue that.
I hope you have addressed all the questions. Can we close the session now?
Yeah, I'm good, sir. Thank you so much for the good questions.
It was an excellent talk, sir. We were really honored, privileged to hear you. Great information.